Yes, 42 years old, Mrs. Jennifer,
Okay.
complaining of fatigue for last 6 months.
Okay.
Just hold on. Mr. Edwin, you are already host. Okay.
Okay.
And try not send other messages because it is disturbing my attention. Okay. Sorry, Dr. Hafsa. Again, 42 years
Yes.
old, Mrs. Jennifer complaining of fatigue for last 6 months.
Okay.
Vitals are within normal. CBC is normal also. Liver function is showing AST 85, ALT
Okay.
88, ALT is 88, and alkaline phosphatase is 700. Okay.
Okay.
Just take 5 minutes. We will start in 5 minutes.
Okay.
So, dear colleagues, I send a message in the chat also. Dr. Hafsa, you just focus on your preparation. Today, dear colleagues, I will explain the details of our upcoming course, also all the details, including the fee structure. So, stay tuned. After Dr. Hafsa is performing this case, then in between I will give the highlights of the course, and then we will do one scenario related to communication skills. Dr. Sattar is around? Okay. If Dr. Sattar is not around, anyone can take the case. Okay, so anyone who is willing to perform in communication can send me the message. So during the course also, we will provide the session recording that will be valid for 3 days. Okay. This is suggested by our colleagues, different colleagues, including Dr. Vikas. So we make the policy like this that during our full course also we'll give the recording that will be valid for 3 days. If somebody is on duty or unable to listen the session can listen that on.
Doctor, I raised my hand for the next communication case.
Who is this? Give me your name, please.
Dr. Vajiha.
Okay, Dr. Vidya, you will do it.
Can I start?
Just hold on 1 minute. Yes, you can start the question.
Okay.
Just let me
Hello.
keep the timing, please. Just hold on. Record the
Okay.
timing. 12 minutes, you will say 2 minutes remaining.
Okay.
Start.
Okay. Hello. Good afternoon. I'm Dr. Roosh, one of doctor in the clinic today. Am I talking to Mrs. Jennifer, 42 years old?
Yes, I'm Jennifer, 42 years old.
Okay. Nice to meet you, Mrs. Jennifer. And Jennifer, today I've been asked to take your history and do your examination. Is it okay for you?
Yes, please.
Can you please tell me what brought you here today?
Yes, doctor, for last 6 months, I am feeling that I am tired all over the day. It was started gradually 6 months ago. Uh, I thought maybe it is because of my busy schedule, but after managing everything, like to have the good lifestyle and taking the good rest, even then I'm feeling that I'm tired all over the day. I went to my GP. He did some blood test and he told me to take some multivitamins initially. So I started the multivitamins, but it did not give me any relief. Later on, I went again to the GP. So he did liver functions, and then he found that something is high in my blood test. So he referred me to you.
Okay. So sorry to hear about it, Jennifer. We will sort it out at the end of the meeting. And do you have any other complaint along with it?
No, doctor, this is the thing. I feel like sometimes that I have heaviness after eating, especially after taking the junk foods.
Okay, okay. And any long-term health issue which I should be aware of?
No, there is no long-term history.
Okay. Are you taking any long-term medications?
No, I'm just taking
Okay.
some treatment for like multivitamins only.
Okay, that's fine. Okay, so is this problem persistently present or comes or goes?
Oh, no, it is persistently present and gradually increasing.
Okay. And is it anything that make it worse?
Nothing significant, but I feel like if I'm doing some work, household work, even household work is just like I cannot tolerate. I feel generally
Okay.
tired. Yeah,
Okay. And anything that makes it better?
nothing. Even after taking the rest, I feel still I'm tired.
Okay. And do you have any weight changes?
Yes, I noticed that I lost 2 to 3 kg in last 6 months.
Okay. Is it intentional or unintentional?
Unintentional, despite of having the balanced diet.
Okay. And do you have any itching over the body?
Yes, I feel I have itching that is coming and going, and I
Okay.
applied different type of lotion, but it is not improving.
Okay. And in which parts there is itching?
It is generalized all over the body, sometime here, sometime there. So it is there.
Okay. Any a specific timing of itching?
No specific timing, but I feel more in the night.
More in the night. Okay. And do you have any rash, spots, pigmentation over the skin?
No rashes.
Okay. Any darkening of your skin?
No.
Okay. Any joint pain?
I had joint pain like 3 weeks ago, and it improved by taking the painkillers.
Okay. In which joint?
It was my right knee.
Right knee. Okay. And okay. Any stiffness in the joint?
No stiffness.
Okay. And did you notice any yellowish discoloration of your body?
No.
Any feeling of sickness or vomiting?
I feel like sickness if I take some junky food, so I used to avoid the junky food.
Okay, and any feeling of fullness?
Yeah, I told you I feel heaviness or fullness after eating.
Okay, any tummy discomfort?
Yes, I feel tummy discomfort in upper part of my tummy, also on the right side of my tummy.
Right upper part. Okay, and any change in your bowel motion?
Recently, no changes. Sometimes I feel that I'm having loose motions, but it is off and on. Most of the time, it is formed this stool, and once I had blood in his stool. It was 1 year ago.
Okay, and how often you have these loose stools?
Like sometime after 1 month or 2 months, like staying for 2 days, 3 days, and then it is improving by itself.
Okay, and any change in color of your stool?
No, it is same. No, the same color.
Okay, any change in color of waterwork?
No,
Okay, any change in amount of your waterwork?
no,
Ever you pass blood in the waterwork?
no,
Okay, and any ever you notice any redness of your eyes?
no,
Any racing pacing of heartbeat?
no,
Any difficulty in breathing?
no,
Any backache?
no,
Okay, and do you have any weather preferences?
no.
Okay, and do you feel dizzy when you stand up from sitting position?
No,
Okay, and are you taking any over-the-counter or herbal medicine?
no,
Any history of hospitalization?
no.
Okay, and sorry to ask, but are you in relationship with anyone?
Yes, I'm married and I have 3 kids.
Okay, and are you taking any birth control pill?
No,
Okay, and any history of pregnancy loss?
no.
Okay, anybody in the family suffering from any health issue which I should be aware of?
No, my mother has high blood pressure and blood sugar, and she's on treatment.
Okay,
My father is having ischemic heart disease, and he is also on treatment.
okay, and do you smoke?
Yes,
And how much and how long?
2 to 3 cigarettes for last 15 years.
Okay, well, smoking is injurious for health, and if you allow us, then I will refer to the smoking cessation clinic.
Okay, doctor, I will consider.
Do you take alcohol?
Yes,
In how much amount?
20 to 22 units in a week.
Uh, well, it's quite on higher side. So I advise you to like ever you try to cut down smoke alcohol.
Yeah, every now and then I try to cut it down, but like sometime we have a party, so it increases. So generally, it is around 20 units in a week.
Okay, it's quite higher side, and I advise you to try to decrease alcohol intake because all your conditions may related to the alcohol itself.
Okay, I will
Okay,
consider that.
and what do you do for a living?
I'm a housewife.
Okay, and how this condition affecting your job and daily activities?
Yeah, of course, it is affecting my daily activities of my household work. I have to take care of 3 kids. It's very difficult to manage, doctor.
Okay, so is there anyone who take care of you and who help you in this regard?
Yeah, my husband is taking care and he's helping
Okay,
lots.
okay, and do you need any kind of support from us?
No, thank you so much.
Okay, and any history of recent travel?
No,
Okay, and one thing I must ask, do you have any difficulty in standing from sitting position?
no,
Okay, and combing your hairs?
no.
And what about your loose tools? Like they are small in amount or large in amount?
No, it is like no, small in amount, not bulky.
Small, not bulky. And are they difficult to flush away?
No.
Okay. And any do you have? Okay, now I'm going to examine you. First of
Yeah.
all, can you please outstretch your hands? I want to look for any nail changes in the patient, and
No need.
then I want to check for any palmar edema and uterine contracture.
No.
Okay, then I want to look for any skin changes, and I'll check the pulse of the patient.
The skin changes. There are excoriation marks of itching on the arms and also on the legs.
Okay, and then I want to check for the pulse, blood pressure.
Yeah, blood pressure is 130 over 80 and pulse is 90 beats per minute regular. No delay, no
O-
radial or epiphyseal delay.
Okay, then I want to check for the proximal myopathy.
No proximal myopathy features.
Okay, then I want to look at the face of the patient, anemia, jaundice, oral cavity.
Looks slightly anemic. There is no jaundice.
Okay, then I want to check for can you please take a sip of water for thyroid? And I want to check for the lymph nodes and JVP in the neck.
Okay. So the lymph nodes not palpable and there is no thyroid swelling, no
Okay,
JVP range.
and okay, then can you please lie down? I want to look at the tummy. Any stria marks, any scratch marks, any distension of the tummy. Then I want to do full abdominal examination for any visceromegaly and shifting dullness.
Okay. Abdominal examination. She is having just like excoriation markers of itching on the tummy also. Otherwise, no distension of the tummy and there is no visceromegaly.
Okay, then I want to check for the knee joint. In which joint you have pain?
The right joint, right knee joint.
Okay, and I want to just move the right joint, or I want to look at the joint, any warm tenderness, any swelling, any movement problem.
Right now, no swelling, no redness over there, and it is not tender. And there is full movement of the joint is there.
Okay, and is the problem of the joint was sudden in onset?
No, it was not sudden, it was gradual in onset, gradually increasing
Uh,
and then improved by taking the painkiller. 2 minutes remaining because you have done a lot of
okay,
examination, so it will cut your time.
okay. So, what are your? I want to check the pedal edema, and what are your concerns?
No pedal edema. Yes, doctor, what I have and why I am having tiredness all over the day. Is it due to
Okay,
alcohol?
so Miss Jennifer, yes, it could be related to the alcohol, and actually, your function of your liver has been disturbed, and there are so many reasons for it. And to rule out the causes, we need to investigate you in detail, and after that, I will be in better position to tell you what exactly is going on.
Okay, so right now you don't have any idea about my condition, doctor.
Yes, there are 2 to 3 causes which could lead to this tiredness. One of the cause is the primary biliary cirrhosis, in which there is some soreness in the lining of liver, and
Mm-hmm.
which could lead to this tummy discomfort and this itching and all the fatigue. The other reason is some soreness in the bowel that can affect the liver, and third one is because of the alcohol. So to confirm our diagnosis, we need to investigate you in detail.
Right, right. Okay, okay, doctor. Thank
Time's
you.
up. Time's up.
Okay.
Time is up, Dr. Afsa. Good history taking and good way of examination. Now your examiners is asking your questions. Okay, give me your differential diagnosis.
My top differential is primary biliary cirrhosis,
Mm-hmm.
and my second differential is alcoholic hepatitis, and
Mm-hmm.
my third differential is primary sclerosing cholangitis.
Good. Why you want to add alcoholic hepatitis when there is no no significant rise in the AST and ALT?
Yes, so it should be third differential. Second would be primary sclerosing cholangitis.
Good. That is how you have to arrange your differentials from outside of the station, and then to the inside of the station you can change.
Yes.
Okay, somebody is having the mic on. Please mute yourself. Okay. So anything else you want to add in your differentials, considering the high LP?
Considering the high alkaline phosphatase.
Yes.
Yeah, it could be some like osteoporosis or CKD. CKD can be like this with high alkaline phosphatase.
Okay. There are no features in this patient, so do not
Yes. No.
do not include irrelevant.
Any other
Indi-
like pancreatitis or else
yes,
she's alcoholic. Yes.
yes, yeah. CA head of pancreas, yes, and
And
cholangiocarcinoma,
cholangiocarcinoma, yes.
and one more.
Choledocholithiasis or
Try to focus on medical causes because this is basis examination. Okay, drug
symptom of
induced.
photoid dysfunction. Yeah, drug induced. Okay.
Okay. You have taken the drugs and you did not find any drugs, but you have to include from outside. Okay.
Okay.
Right. Okay. Tell me your investigation panel.
Okay. First, I will run all the baseline investigation, complete blood count, ESR and CRP level, and liver function test, kidney function test, prothrombin time, INR, albumin to see liver
Mhm,
synthesis function. And
mhm.
then for specific investigation, we can go for anti-mitochondrial antibodies
Yeah.
and ANA profile, a
Mhm,
thyroid profile of this patient, and ANCA, P-ANCA and C-ANCA level. And
mhm.
then we can go for ultrasound abdomen, ERCP and MRCP of the patient. Then we
Okay.
can go for CT abdomen with contrast with pancreatic protocol to rule out pancreatitis. And we can do liver biopsy as well.
Okay. Now one by one. Uh, we have to be very specific for the investigations. Also, there should be reason for investigations. So, because the examiners and RCP also very much concerned that we should not do unnecessary investigations because it is
Yes.
like playing with the justice of the patient. And okay,
Yes.
tell me why you want to do the thyroid functions here.
Yeah, usually primary biliary cirrhosis is associated with the thyroid related disorders. So to rule out other autoimmune, we can go for it.
Better not to say, right? Okay, and why
Okay.
the vasculitic workup here?
Usually in primary sclerosing cholangitis, ANCA is positive.
Oh yeah, this is good. Okay, and ERCP and MRCP you want to do, then CT
Yes.
chest, CT abdomen you want to do with
Yes.
monolytic. Okay, good. So tell me, uh, what antibodies will be positive if it is primary biliary cholangitis?
Anti-mitochondrial antibodies would be positive.
Okay, which type? M1 type or M2 type?
M1.
M2 subtype. It is positive in
Okay.
98% of the cases.
Okay.
Immunoglobulin level also is high, that is IgM in primary biliary cirrhosis.
Okay.
Okay, tell me the what antibodies could be positive in case of primary sclerosing cholangitis?
IgG would be positive.
Antibodies.
Antibodies in primary sclerosing cholangitis.
Yes.
I don't remember.
Okay, it is ANA and anti-smooth muscle antibodies will be positive in primary
Okay.
sclerosing cholangitis. Okay, and in which disease? In which disease this PRCP and MRCP is specific? Okay, Dr. Hafsa is not around, so anyone can take up the case from here and proceed.
Yes, I'm here.
Oh, okay, sorry. So what antibodies will be positive in primary sclerosing cholangitis? We were discussing it is ANA and anti-smooth muscle antibody could be positive. Okay, what will be the findings? Okay, in which case we will do ERCP and MRCP?
Hello, sorry.
Yeah, I think you can keep mute. We can discuss now, Dr. Hafsa, and you can listen.
Okay. Okay. Thank you.
Take your time. Okay, so colleagues will highlight the investigation panel in primary sclerosing cholangitis. So ANA and anti-smooth muscle antibody will be positive, and then the ERCP and MRCP. So these are the specific tests for primary sclerosing cholangitis. So what we will see in MRCP, there will be beaded appearance of biliary tract. Okay, so in this patient, there are two top differentials: primary sclerosing cholangitis and primary biliary cirrhosis. In this patient, I will go with for primary sclerosing cholangitis because in this patient,
Hello.
hello, yes.
Yes, sir. ANA and asthma is positive in autoimmune hepatitis. That's not in PSC, sir. I think Bianca is positive in PSC, right?
Okay, I will give you the reference, please.
And second question is why we are doing ERCP in case of PSC.
Okay, I will give you the explanation. Good question, doctor. We'll highlight this in a minute. Okay, so let us discuss about the differentials here. Here are two differentials are more here, like primary sclerosing cholangitis or primary biliary cirrhosis. So in both of the scenario, from outside you will see this alkaline phosphatase is high, and both of the cases will be middle-aged lady. Both will be presenting with like fatigue or tiredness. Okay, and both could be having the like itching in both cases. Okay, so how to differentiate from primary biliary cirrhosis and from primary sclerosing cholangitis on the basis of history and examination. So there could be xanthelasma positive in primary biliary cirrhosis. Together with this, both patient can have diarrhea. In primary biliary cirrhosis, the diarrhea will be malabsorptive type. Okay, that is not present in this case. Malabsorptive type of diarrhea is usually the patient will say that I am having bulky stool. Okay, and it is foul smelling. It is difficult to flush. So these are the features of malabsorptive diarrhea. So here there is no history of large stool, bulky stools, and there is no history of difficulty in flushing of the stool. So there is no history of smell. And here the patient told there was blood she passed in the stool some time ago. So it is indicating that this patient is more in favor of primary sclerosing cholangitis. Primary sclerosing cholangitis is commonly associated with inflammatory bowel disease, mainly the ulcerative colitis. So here we have to keep two top of the differentials, primary sclerosing cholangitis and primary biliary cirrhosis. In this case, goes more in favor of primary sclerosing cholangitis. The both patient will be like they will be both in a childbearing age. Okay. The investigation panel, as we discussed, there are some question about which antibodies will be positive in primary sclerosing cholangitis. I will just highlight this now. So focusing the baseline investigation, we have to say like this, that we'll do the complete blood cell count, urea, creatinine, electrolytes, LFTs, ESR, CRP. These are all correct. Then the autoimmune workup, that will include the ANA, anti-smooth muscle antibody, antimitochondrial M2 subtype, IgM level, and then we have to involve the other test also, like if we are keeping the differentials also autoimmune hepatitis, then again we have to include anti-liver kidney microsomal antibody type 1. Okay, so these are the workup for all autoimmune diseases related to liver problem. Okay, so now I would like to highlight especially about the primary sclerosing cholangitis. Just hold on. So the specific investigations for primary sclerosing cholangitis, you will see like the alkaline phosphatase will be high, bilirubin would be high, and in this condition, primary sclerosing cholangitis, IgM gammaglobulinemia will be there, hypergammaglobulinemia, and or increase the IgM level. Okay, antimitochondrial will be negative. Antimitochondrial is positive in primary biliary cirrhosis, not in primary sclerosing cholangitis. But ANA and smooth muscle antibody will be positive, and ANCA may be positive in primary sclerosing cholangitis. Investigation ERCP and ERCP, MRCP will do, that will detect, we will find out this, there is biliary duct abnormalities. Like as I told you, it is specific. BD appearance will be specific in MRCP, magnetic, this one cholangiopancreatography, retrograde, magnetic, MRCP stand for magnetic retrograde cholangiopancreatography. Okay, so in this condition, what we will see that the duct has got beaded appearance, or there are strictures here. So it is sometimes difficult to differentiate from cholangiocarcinoma. So first test is non-invasive, that is MRCP. It will give us the idea. It is like there is some destruction, some stricture formation in the biliary tract. So then we will go for ERCP. Why we are going for ERCP? We are going for two reasons. Because we have to take the biopsy to rule out cholangiocarcinoma, number one, and then sometime we have to place the stent also. So it will give the relief to the patient, because of this stricture formation and changes in the structure of the biliary tract, patient is having cholestatic jaundice. This patient is not having cholestatic jaundice, it is an early stage, but later on, these type of patient can have cholestatic jaundice. So to relieve that, they have to do ERCP, and they have to do ERCP for two reasons. One is to get the biopsy to rule out the cholangiocarcinoma, and the second is to place the stent to relieve the obstruction, the partial obstruction. Okay, now we are moving towards the treatment options. So mainly I'm focusing now primary sclerosing cholangitis. It is progressive disease, okay, and this is one of the commonest causes of liver transplantation. The patient will need the liver transplantation, but it is at the late stage or end stage of the liver disease. Okay, Sometimes the examiner may ask you after the liver transplant, what are the condition in which the liver transplant, even the patient having liver transplant, and then the patient can develop again these features. So primary sclerosing cholangitis is one of the condition where after the transplant also patient can develop again these changes of biliary tract. Okay, this is primary sclerosing cholangitis is more worse than primary biliary cirrhosis prognosis wise. It is associated with inflammatory bowel disease. Okay, so almost 80 to 90% of the cases they will have inflammatory bowel disease. So we have to do workup for inflammatory bowel disease also for a patient who is having primary sclerosing cholangitis. 80 to 90% of the cases they will have inflammatory bowel disease. So we'll go for colonoscopy, and somewhere we have to take the biopsy also to rule out whether the patient is having inflammatory bowel disease or no. Most likely patient will be having inflammatory bowel disease also, mainly ulcerative colitis stuff. So this is about the association between primary sclerosing cholangitis and inflammatory bowel disease. Okay, in relation with this, I want to tell you about if the patient is having like inflammatory bowel disease, if you have a case of inflammatory bowel disease, then there is a reverse relation with primary sclerosing cholangitis is also there, but it is not as much as in case of primary sclerosing cholangitis. I mean, if the person is having inflammatory bowel disease, 10 to 20% cases will be having primary sclerosing cholangitis. For that, we have to do the follow-up of the patient with LFTs. I think it is clear. Okay. And the prognosis is worse. If primary sclerosing cholangitis patient is, if he or she is having inflammatory bowel disease also, the prognosis is worse. If the person is having only primary sclerosing cholangitis, then the prognosis is not that much worse than if they have both the diseases. And then there is increased risk of developing colorectal carcinoma also in these patients with the primary sclerosing cholangitis having the inflammatory bowel disease also. Okay. So the ERCP we are doing to take the biopsy to relieve the obstruction by putting the stent, and sometimes they are doing the dilatation of the biliary tract also. Then there are supportive treatment for both primary sclerosing cholangitis and for primary biliary cirrhosis. That includes like ursodeoxycholic acid. The patient is having itching, so we can use ursodeoxycholic acid and cholestyramine. So remember these medicines also. Patient usually having tiredness, so you can add modafinil also. Okay. This ursodeoxycholic acid may improve liver functions in cases of primary sclerosing cholangitis. But there is no survival benefit for patient if the patient is taking ursodeoxycholic acid. Okay. Cholestyramine is another option. Okay. And there are other supportive treatments. So any question for this case? Okay, there is no question. Then I will proceed just to give you some information about our upcoming course. There are many questions, so let me highlight this. So, Mr. Edmund, can you share the slides? Okay, so our course will start from February 7 to 27 February. There will be 15 sessions. Every session will be like 2 to 3 hours long. In every session, I will try to do 5 cases. So, and like I will be having 2 sessions for clinical, and then the third session will be for the communication skills. The pattern will remain more or less same. After 2, there will be 1 communication skills station. So we will focus like 2 days on clinical stations, then 1 day our communication skills. This will give us the better idea about our cases. If we are doing mixture, then you may not pick up the findings very effectively. So this will be the pattern. So we'll try to do 5 cases in a day uh, for clinical long sessions. So 5 means that 10 sessions will be related to this. So most likely we'll cover 50 cases, 50 plus cases, and I will give you 50 plus cases. So with the highlights and with the approach. Okay. Then the third day, every third day will be the communication skills. We'll try to cover 6 cases of 6 scenarios of communication skills. So we'll try to finish 30 scenarios in 5 stations, in 5 sessions or 5 days. So this will be the detail. This is the detail basically. And go to the next slide, please. Okay. So this is the highlight for communication skills. We will do the introduction, and then we will do the breaking bad news scenarios. We will do some diseases scenario where we have to explain the disease scenarios. We have to we will have some uncertainty cases. We will have medical procedure related scenarios and scenarios in genetic counseling. Okay, medicine related scenarios. How to deal with the angry patient. How to break the bad news. How to explain the palliative care. Okay, some of the infectious disease scenarios, functional disorder scenarios, suicidal attempt scenarios. Okay, refusal of treatment or refusal of procedure related scenarios, and some legal issues and according to the scenario we will discuss, like DNR, how to do it, and maybe we'll do the post-mortem related scenario also. This is about the communication skills topic. Next, please. Okay, long clinical consultation cases will be like pulmorenal cases, vasculitis cases, cardio cases, respiratory cases, rheumatology cases, endocrine cases, gastrointestinal related cases, CNS cases, derma related cases, renal cases, and some general cases. So mostly it will be like 50 plus cases that recently coming in the exam, frequently coming in the examination. We will discuss, not only we will do the cases, but also after the end of every case, we will do the mock like scenario. We will make it like we will discuss how you will approach and what should be the differential diagnosis or diagnosis in this case, how you will investigate and how you will manage the patient. So in the exam, after doing the history and examination, the first question from the examiner will be like this: what is your presentation? Present your positive findings, or he will ask you what is the differential diagnosis. And the next question most likely will be how you will investigate. And the next question will be how you will manage the patient. So we will go with the same approach. Okay. So these will be the cases, and we will go with this sequence most likely. But highlight of course will be like I have the different approaches for different types of scenarios. How to go and narrow down your differential and to reach to the reasonable or most likely diagnosis. So this is the brief introduction about the course, but it is really full of all the information in depth, and it is practically an exam oriented type of course that will give you very good information about the basis exam. And for the beginners really it will be the very informative. And for the active participant, they will be doing their practice, they will shine their knowledge, and they will be ready for the exam within 2 months of the course, most likely. This is my assessment as I'm doing these courses. Previously, I was doing 1:1 session, so have passed many candidates, UK based also, and Pakistan based also, and Dubai based also. So mainly I was doing the 1% or 2% sessions. So now I'm doing like the big courses. So I have the lot of cases, like 100 plus cases recently coming and frequently coming exam cases. So this is all about the structure of our course that is starting from 7th February. Now the frequently asked question is about the fee schedule. As this is my first long course, so I'm considering the candidates relating to Indo-Pak. So I offered like 25% discount, but now it is almost like 50%. So it will be $60 for the listeners, and it will be $80 for active participants. We have already selected the active participants, remaining 1 or 2 slots only. So for the active participant, only 1 or 2 slots remaining. Anyone who is interested, just give us the positive feedback or your inclusion tomorrow or day after tomorrow. So we will finalize the list of active participants. For the listeners, it will be like $60. So these are the information about the course. Any question or any suggestion about the course? Timing already mentioned here. So it will be like 9 p.m. UAE time, 10 p.m. Pakistan time, 10:30 Indian time. Okay, so this will be the timing schedule. It will be 8 p.m. Saudi Arabia time. So any question or any suggestion, you are welcome. Okay, Dr. Wajiha, are you ready to perform your communication skill scenario?
Yes, doctor.
Okay, thank you. I'll give you the scenario now. Okay, I'm sharing this scenario in MRCP group. Are you there in MRCP group, Dr. Wajiha? Mr. Edwin, can we share the scenario here? Dr. Wajiha, are you checking the scenario? I will write here also, no problem.
Yes, I am sharing. Wait.
Okay, thank you.
I've seen it there and I'm preparing. I'll let you know as soon as I'm ready.
Okay, take your time. Great. But Mr. Edmund, you can share here also, please.
Okay.
Well, I'm ready. Hello? Doctor, can you hear me?
Yes, yeah, Dr. Vijay. 1 minute. Just give me 2 seconds.
Okay.
Yes, yes. Are you hearing me?
Yes.
Okay, just hold on. Give me a few seconds.
Okay.
Okay, Mr. Admin, we have to keep the timing for 8 minutes. When the 8 minute finishing is announced, 2 minutes remaining. Dr. Vijay, you can start now.
Yes. Hello, my name is Dr. Toor, and I am one of the doctors in the unit today. May I confirm, am I talking to Mrs. Smith, 25 years of age?
Yes, Dr. I am Smith, 25 years.
Well, Mrs. Smith, I'm here to talk to you regarding the recent tests that were done on you and explain the results. But before I explain any further, may I know what is your understanding of what is being done on you?
Yes, doc yes, doctor. Actually, my father is having some kidney disease. He's on, like, he was on dialysis through his tummy, and it was recently he developed some infection also in the tummy. That is why he's suffering too much. Some doctor told me that it is this disease is running in the family, so better you should do your testing also. So they did my test, and I'm here to receive the test results.
Okay, Mrs. Smith. Thank you for sharing your information, and I'm really sorry for what your father is going through. Okay.
Yeah.
Well, like you said, the tests were done and the reports are with me, and I'm sorry, but the results are not as we hoped.
What do you mean by that, doctor?
I mean, Mrs. Smith, the results of the scan that were done, they are confirming that you have these polycystic kidney disease, the same problem that your father had to begin with. Um,
Are you sure,
are you
doctor? Are you sure, doctor? Is it my report?
Well, Mrs. Smith, I can understand that this is a big, it must be a shocking news to you, but let me tell you that it is your report. We've confirmed it, and you do have this problem as well, which we call as the adult onset polycystic kidney disease.
Oh my God,
Okay.
doctor. Oh my God. Oh my God. So I will also go through this dialysis procedure. I'm really
Mrs.
shocked.
Smith, Mrs. Smith, I'm sorry that I am the one delivering this news to you, but let me just tell you that, we're there for you and we're there to treat you, we're there to manage you, and we will hopefully, with the right management and the right plan, hope we'll be able to keep things better under control. Okay.
Okay. So can you
Uh,
prevent me from dialysis, doctor? Can you prevent me from the dialysis?
Mrs. Smith, well, I cannot assure you on that, but all that I can tell you is that we will provide you with the best management, the best care, and we'll try to control your disease as much as we can, or we will try to prevent any complications from occurring. Okay?
Okay, doctor, you are telling some complication about this disease. Can you tell me the complications? I'm really very much worried about this disease and
Well,
the complication. What complication
well,
could be?
well,
Yeah.
yes, Mrs. Smith. Well, I can understand that through your father, you must have seen how the disease has affected him. But since now that you also turn out to be having the same disease, I believe it would be wise if I tell you, how it can affect you and where we need to be watchful for. Okay?
Okay.
Okay, so this disease, Mrs. Smith, it's something that runs in the family, and probably that's the same reason that you have it as well. Well, primarily it is to do with small pockets of air that can form within any of the body organs, importantly the kidneys. Okay,
Mhm.
we
Okay.
call them cysts, and that's what's that's where the problem related to kidneys or related to the dialysis your father's been having. I'm sorry to tell you, but that's a consequence or a complication of this disease if it is there in the kidney and it keeps on building up. Okay.
Okay.
Okay, okay. Other than that, Mrs. Smith, these same pockets can form in other organ tissues in the body as well. I mean, there's a possibility of it developing in your liver or in other organ body tissues as well. Also,
Mm.
Mrs. Smith, I mean, I'm sorry, it's quite a lot of information and it must be difficult for you to take, but are you okay with me continuing?
Yeah, please, you can continue, doctor, because I'm very much concerned about all these things and I want to listen.
Okay, so Mrs. Smith, well, of the things, one complication that is, worrisome, and we will be very carefully what we will very carefully be watching for, is these it could cause some problems in the blood channels of your brain as well, and as long as they're carefully monitored and watched for, they do not cause any further complication or harm. But I'm sorry, but in the worst events, they can rupture and they can cause bleeds. But these are the worst complications that I'm telling you of. Once
Mhm.
again, I'm sorry for that. But
Okay.
well, this is what the disease is about. And
Okay.
Mrs. Smith, there's one more
Yeah.
thing concerning that, as I told you earlier, it is a disease that runs in the family. You got it from because of your father. So there's
Yeah.
always a possibility that, in the future, when you'll have your children, we'll have to screen them as well for the same.
Oh,
Um,
doctor, this is really, really another very bad news for me, doctor. Can I tell my fiance about this disease? because we are going to start our family. We are planning to start our family.
Mrs. Smith, I believe that now that you know that you have this disease, I mean, if you want to, you can always share it with your fiance. But at the same time, it would be wise that if you plan to start a family, we to begin with, it would be wise to involve the women doctor, the team, we to keep them on board, and then at the same time, also, if at all, we will also have the choice of, making sure or keeping in check if your baby also has the same problem. Okay. Once again, the
2 minutes
possibility
remaining.
cannot be ruled
2
out.
minutes remaining.
Ruled out. Okay.
2 minutes remaining.
Okay. And as such, there's I mean, whether your children would have it or not, it is too early for me to say. But we can, look into the possibility of making a team and looking into involving the genetic doctor, the gene doctor as well, and see what can be done to help you out on that. Okay.
Okay, what is the risk? What is the risk for my children? And what is the risk? How many percentage does
I
my
mean,
children?
well, it is a 50% chance, Mrs. Smith, that your children would have it. Okay.
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 And can I
Okay.
save my child? Can I save my child?
From you, from the developing it all together.
Yeah.
Mrs. Jean, I'll have to check with my team as well on that, whether if there's a choice available on that or not, and I'll get back to you on that as soon as I have an answer. Okay?
Okay. Thank you.
Okay, and all along, Mrs. Smith, from here onwards, now that you are known to have this disease, we'll be keeping you on regular follow-up. We'll be scanning you. We'll be running blood tests on you regularly, just to make
Yeah.
sure that things are under control. And if at any point we find any complication, we'll be in a better position to deal with it. Okay, there and then. Okay.
Okay. Yeah.
And relevant to all that I've explained to you, I will be handing you information that you can go through. Our contact number would be on that as well. And if you have any questions, any queries, you can always come back to us. Okay?
Okay.
Once
Thank
again,
you.
I'm sorry, that your father's gone through all of this, and we will try in our best capacity to deliver you the best possible care that we can, and avoid any bad complications. Okay, but I mean, since this is the natural course of the disease, so I cannot guarantee you on that. Okay, I'm sorry for that
Okay.
though.
Okay.
Okay.
Thank you. Thank you,
Okay.
doctor.
Thank you.
Okay. You can give brochures in the leaflet about the disease at the end.
I did give them. I said
Ah,
I'll give you written information.
written information. Okay.
Time's
Thank you.
up. Time's up.
Okay, Dr. Vadiha. I think generally very good performance about the case. Just I want to give you some important tips to improve this scenario. You can do next time if this comes or such type of scenarios coming in front of you, and you can do in a better way, more better way than this way. This one is really better way to perform very well. So every time when we perform, there are chances that we should have some improvement.
Okay.
Okay. So at the start, when you started, if you ask her, anyone you want to be with us today, it will be great because this is a scenario of bad news. Okay, like she raised the issue later on about the fiance, so you can ask at the start, would you like someone to be with us in this meeting? So most likely the patient or the relative will say, no, I'm here. That's it. But you have to ask. Okay. Then you started with very good, like with sympathetic way and empathetic way. This remained nice and well throughout your communication. This was a very good findings. When you started and you said sorry for the condition, and then immediately you went to her diagnosis. in between you should give some pause, and then you should give the news like this, as you did. That I'm sorry to tell you that I'm having the report that is not as we were hoping. So there should be pause in between. That is known as golden pause. Okay, and in between your talk, you have to say different words. Like you used the word okay for many times, multiple times. So sometimes you have to use like, are you with me? Are you getting me? Is this okay? Do you want, are you getting me? Do you want anything to explain you more about this? So like this. So you have to talk like maximum 30 seconds, and then you have to take a pause and you have to say some words alternatively. Sometime is it okay? Sometime are you with me? Are you getting me? So at least three, four words you have to make your habit to change alternatively.
Okay.
And sometime, like in this scenario, there are complications, lot of complication associated with autosomal dominant polycystic kidney disease. So here we should avoid to give all the complication in one go. Okay. So better not to say like. And you said this cyst can be formed in any organs of the body. Is this like this?
I said many organs actually, but I should have specified.
Yeah, you just said either to escape or to skip this, or you may say this can be cyst or the water-filled sacs can be formed in some other parts of the body also, like liver. That's it, and sometime in the brain. That's it. These two
Okay.
is
Okay.
yeah, because these are the two other specific areas. Otherwise, there is like can be in the spleen and pancreas and epididymis, yes, and sometimes some associated cardiac issues like mitral valve collapse. But you need not to give all the bad news in one go. Okay, so the second thing in this scenario, did you notice that her kidney functions are normal right now?
Yeah, her kidney reports were normal for now. Everything was okay.
Yeah, did you reassure about this?
I missed that. That was very important, and I missed saying it.
Yeah, this is very important in this case, and blood pressure also normal.
Yes.
Okay, so we have to read the communication scenario word by word, okay, and try to write down in your paper also. Take your full 5 minutes whenever you are outside the station, and you have to write down the things in chronological orders or in a sequence. Okay, how it is given, and what we will address first, and what we will address second. Make your list, so you will not miss anything. So in this scenario, our blood pressure is still normal, and kidney functions also normal. So you can reassure her that, yeah, you have been diagnosed as a case of polycystic kidney disease on the basis of the jelly scan. But good news is that your blood pressure is still normal and your kidneys is still functioning very well. So what we will do now, we will follow you up and with your kidney functions, and we will keep a check on your blood pressure. Okay, we will give you the best possible care, and we will try to prevent you from having the dialysis, although I cannot guarantee. It's a progressive disease. It will proceed to that stage, but we will try to keep you under follow-up. We will try to do best possible efforts that you should not reach to that stage of kidney failure that where you need the dialysis. But doctor, will I need the dialysis? I'm sorry. Any patient of this condition, with the passage of the time, they need dialysis or even the transplant. But at present, you are asymptomatic. Your kidney functions are normal and your blood pressure is normal. What you need is you have to be in regular follow-up with your doctor. He will do your kidney functions every now and then, and might be the jelly scan as needed again. With decent follow-up, with regular follow-up, you can maintain your kidney function in normal level for considerable period of time. Okay. Then Will I need will I need the brain imaging also? If you told that there is cyst, it can be formed in the, or that there is dilatation of the blood channel in the brain, that is association aneurysm, you mean? So will I need the brain imaging? There could be different questions. Just it is not related to your case, but I'm trying to cover this case from all directions. Okay, are you with
Okay.
me, Dr. Vijay? Yeah. So
Yes.
I'm just highlighting for you and for the audience also is what could be the concern raised by different surrogates in different countries. So will I need the brain imaging? Okay, then this is indirect question. Then you have to ask another question. Did any one of your family member who is having this disease or your family member having bleeding inside the brain? If yes, then the brain imaging will be needed. Otherwise, just I will give you the red flags that if you develop severe headache anytime of sudden onset, you have to come to the emergency department, A&E, and you have to inform that you have this disease, that's polycystic kidney disease. So your doctor will take care of you, and likely they will do the brain imaging immediately. Okay. Then the other issue in this patient, I tried to give you just like the hint that thank you when 2 minutes was remaining to touch the social history and personal history. Okay, then you have to ask about the smoking. She is a smoker, so you have to say uh, high blood pressure is associated with this condition. If you will continuously smoking, it will increase the chances of high blood pressure, and it will increase the uh, risk of your kidney problems will be increasing. So I will highly recommend you that you should stop smoking, and for this I will refer you to the smoke cessation clinic. Okay, clear.
Yeah.
And at the
Okay.
end, you have to give some advices also. So uh, I will advise you to keep yourself in regular follow-up. Avoid contact sports, very important. So you have to ask about the hobbies also in social history in this patient. This is hidden agenda. Some people out there playing like rugby or some other contact sports. So you have to avoid heavy exercises also, vigorous exercises also, and also contact sports because it will increase the risk of rupture of these uh, sacs or cysts that can lead to blood loss and can be very painful for you. You have to inform to your GP. You will write the letter to your GP also, and you will inform that you have this condition. So any doctor you are visiting or going for any reason, you have to inform you have this problem. So they will avoid any drugs causing damage to the kidney. Nephrotoxic drugs, I mean. And the minimal analgesia should be used. Avoid the analgesias also. Okay. If you develop severe headache, again, I'm just now doing in safety netting or advices session. If you develop severe headache anytime, come to A&E for assessment first, and then the doctor will decide about the brain imaging. About the pregnancy issue, like this patient raised a pregnancy issue, otherwise it is not raised in the communication. She may raise in social history. Whom do you live with? I'm living with my husband or with my fiancé. We are going to start the family. So very important this one consent. So it should be planned. Blood pressure should be controlled. Okay, and should be followed with the kidney doctor, HCP, woman doctor. All should be on board. Okay. Uh, if you go to any doctor, then you have to inform the disease about this. Yes, we have done this. Okay. Can I get pregnancy? Yes, you can, because this disease does not affect your fertility. But pregnancy should be planned and it should be followed by the kidney doctor, blood pressure doctor, woman doctor. Good control of blood pressure is compulsory. Can my child be affected? I'm sorry to tell you, yes. It's a disease that runs in families, so your child can be affected. What is the risk? It is 50% chances with every child, with every pregnancy. So can I save my child? Yes, you can. Pregnancy should be plan number one. Number two, you will be referred to genetic doctor, the gene specialist doctor. These are this specialized team. They will guide you and they will discuss with you about in vitro fertilization. What they will do, they will assess the female gametes or the cells um, called ova. They will select the healthy ova that is not being affected by this autosomal polycystic kidney disease. The genetic testing will be done. They will select the uh, healthy or normal ova and mix up with the sperms, and then they'll do the in vitro fertilization, and then they can implant it. But even then, remember, you have to inform to the patient that even with the IVF, there is no 100% guarantee that the disease will not be uh, going to the baby. So the risk will be reduced from 50% to minimum. I cannot give you the exact decrement, but I cannot give you at the same time that 100% guarantee that your baby could be saved. Okay, then should I tell to my fiance? I advise you to tell him about your health condition. He will help you in long term. Okay, and he will be trusting you. And if you will not tell him later on, if he comes to know, he will not be happy. He will be stressed. So uh, you should inform, and you should inform, not me. Maybe in some time they will raise the issue. Doctor, will you breach the confidentiality? Will you tell to my fiance or no, no, we are not going to tell. This is highly confidential what we are discussing with you. But I suggest you that you should inform. In such scenarios where we should inform to the partner, then we have to give the option to the patient that he or she should inform to the partner. Okay, but we can offer them help. If you want my help, we can have another meeting. You can call your fiance, so we can discuss and we can explain to him also. So it will be easy for him, for her. Okay. Is it serious? I'm sorry. Yes, it is serious. If it is not treated properly, if it is not managed properly, if it is not followed properly, yes. Okay. Other complications that are very important include like recurrent infections. Have to inform. Sometimes the ruptures of the cyst can occur, especially after the trauma. So avoid the hobbies like contact sport. Renal failure. To avoid the renal failure, they have to do kidney function every 3 months, and blood pressure and kidney functions uh, are monitored regularly. Blood pressure should be monitored at the home also, at the follow-up with the GP every month. But kidney function can be done every 3 months. If it remains stable, then you can increase the duration to 6 months. But if the patient is going for pregnancy, then it should be very frequent with the woman doctor also. There another risk of recurrent stone formation. In that condition also, you may have the blood. In all these conditions, you may have the blood in your whatever, like the patient having rupture cyst, or the patient is having a stone, or the patient sometimes with infection can have also. Okay. Yes. Any important thing in this? Let me check. Okay. She may raise the issue that my brother and sister, I have two brothers and one sister, so what is the age? She may ask me, uh, should they undergo also the testing, find out whether they have got this disease also or no. So anyone who is having the age more than 20 years, he or she should undergo to ultrasound to find out whether the uh, same problem is there or no. Less than 20 years, just inform when he or she will reach to the 20 years, it is advisable to do the testing at the age of 20 or above. This is another issue. How frequently the pregnant ladies should follow without autosomal dominant polycystic kidney disease? Every month. Blood pressure monitoring and every month. KFT. Otherwise, without the pregnancy issue, every third month kidney function test. Okay. Is it curable disease, doctor? No, it is not curable. It is progressive disease. I'm sorry. Okay, in pregnancy, what are the risks associated with autosomal dominant polycystic kidney disease? In pregnancy, gravid uterus, the big uterus is compressing, causing pressure on the kidney, so it can lead to deterioration or worsening of the kidney function. It can lead to renal impairment. So it will increase the chances of blood pressure also. It will increase the risk of condition known as preeclampsia. It will increase the risk of renal failure. So there are 3 or 4 three risks at least uh, in pregnancy. Number one, increased risk of uncontrolled blood pressure, increased risk of preeclampsia, increased risk of worsening of the kidney functions. Okay, ethical issues and legal issues in this case. Ethical issues, we should know, now in the exam they are not asking ethical and legal issues, but indirectly it is coming in front of you. Like the patient will raise the issues, some issues I will highlight now. Like uh, ethical issues, autonomy. Patient has the right to know each and everything about the condition. Beneficence is, in this patient, the beneficence will be regular follow-up, blood pressure checkup, kidney function according to the guidelines. Non-beneficence in this patient will be avoid nephrotoxic drugs, avoid contact with sports, avoid unnecessary investigation. If we ask you to do the CT scan now, it is not indicated right now. Whenever it is indicated, we'll do. Just this, we have to uh, provide the best possible care, regardless of age, sex, and religious belief of the patient. If patient demands unnecessary investigation like brain imaging, this is out of it is against the justice. So we have to use in justice point. Another justice point is we have to use hospital resources judiciously as per indication. So this is ethical issue. Legal issue in this case is confidentiality. Will you tell to my fiancé? No, I will not. But I will advise you. I'm advising you. You should inform. I can help you. So these are the things in this scenario. Let me check the chats. Any questions? Any questions?
Doctor, just give me my score. I mean, just an honest score for what the way I was performing. I've realized my shortcomings, but what would be the score
The score in this
for me?
scenario will be 14 out of 16.
Okay.
It is great.
Okay. Thank you.
It's great. Yes, it is great. It will be 14 out of 16. And I highlighted the something that you have to improve. And likely, if you will perform the cases like this, no doubt you will get the full marks in your upcoming exam. There are 2 things in
Okay, thank
communication.
you.
Yeah, there are 2 things in communication skills. One is performance that will come by the practice. And the second thing is knowing about the cases. There are a variety of cases coming and the different types of the cases they are coming. So if you don't know, for example, if some new case comes in front of you and you don't have the idea, although you have done a lot of practice and you know that how to perform, you will overcome to that extent that you will pass, but you will not get the full marks, for example, if it is something new scenario. So to be familiar with the scenarios, it is very important to listen the cases coming with different hidden agendas and doing the practice. These are the 2 important points I would suggest for all. So participants, any questions from your side? Great to be with us. Thank you so much. Have a good night. And this recording will be available in our group on WhatsApp, and it will be valid for 3 days. And try to join our upcoming course. A lot of information, lot of help is there. So it is like whoever is prepared for the exam, also good for the practice. Whoever is just starting, it will be a very helpful course for them. Thank you so much. Good night, Dr. Nadeem and Dr. Vikash and all colleagues. Dr. Vajiha, thank you so much for performing today. Anything you want to say, Dr. Vikash?
No, sir. Thank you, sir.
Okay, thank you so much.